All right, welcome everybody to today's noon webinar for Penn AI Tech. Penn AI Tech is the Penn Artificial Intelligence and Technology Collaboratory for Healthy Aging, an initiative funded by the National Institute on Aging. And today we're very happy to have with us Dr. Martin Michalowski, who comes to us from the University of Minnesota. He's an associate professor in the School of Nursing and co-director of the Center for Nursing Informatics at the University of Minnesota. He's a co-leader of the Digital Health Lab at the university, a co-leader of the Mobile Emergency Triage Research Group at the University of Ottawa, and director of machine learning research at treatment.com. His research portfolio includes novel contributions, information integration, record linkage, heuristic-based planning, constraint satisfaction problems, large language models, and leveraging artificial intelligence methods in nursing informatics research. His interdisciplinary research brings advanced AI methods and models to clinical decision support at the point of care and personalized medicine. We're very happy to have him today for the webinar. Just to remind our attendees that you can use the Q&A feature, and after Dr. Michalowski's presentation, we'll have a chance for Q&A where I can get to read your questions. So with that, Martin, I'll turn it over to you.
Great, thanks, George. Let me share my screen. Can you see that?
Yes.
Great, thank you. Hi, everyone. Thank you very much for inviting me and having me here. I'm excited to talk about our research in addressing multimorbidity in the context of clinical decision support. Just very briefly, I'm going to talk about the problem that we're addressing. I'm going to present an acronym without a definition first. So I'm going to talk about MGCDS, which I'll define and expand shortly, and really focus on the explainability component of the decision support problem that we're addressing here, and then go through some of our research and our studies that we've done in this area, and finish with some discussion and ongoing work that we're doing. So just quickly, George gave a really nice introduction to who I am, but I'll just very quickly let you know that I am a computer scientist by training. As George mentioned, I hold several academic positions at the University of Minnesota and elsewhere, and I come from a private research lab before I became an academic. And also I do enjoy entrepreneurial endeavors, and all three of these aspects inform the research that I'll be presenting today. So let's get into what is the problem that I'll be talking about that we address. So for those who aren't familiar, the motivating problem we're addressing is multimorbidity. So as we know, people are living longer, so populations are aging, mortality rates are going down. So the issue of multimorbidity, which is the presence of two or more conditions, and as well as polypharmacy, are really becoming prevalent. And within the context of decision support and clinical decision support, multimorbidity really presents a problem. What we're trying to do from a decision support perspective is take evidence-based guidelines, so clinical practice guidelines, CPGs, that are really knowledge-based tools for disease-specific patient management. And we're trying to apply these concurrently to address the multiple conditions that a patient has been diagnosed with and is being treated for. And these concurrent applications of CPGs might offer conflicting advice. So then some of the issues that have really been identified as far as major shortcomings of CPG uptake in clinical practice is this concurrent use of guidelines for multimorbid patients, given that it is difficult and potentially problematic. And then additionally, you know, the challenges which have been identified quite a long time ago and are still being addressed are, you know, this ability to identify and eliminate redundant, contraindicated, you know, potentially discordant and mutually exclusive recommendations when treating a patient who presents with comorbid or multimorbid conditions and is on multiple medications. So this is the space that that we're working in. So as a means to address this, and as a reminder, clinical practice guidelines, CPGs, these are general, they're evidence-based recommendations, but they're also not personalized to specific patient encounters. And really what needs to happen is that we need to integrate these CPGs to care flows and EHRs and to provide actionable recommendations for care providers. In our case, we focus on physicians at the point of care. And one way that this issue has been addressed is through what are called computer interpretable guidelines, or SIGs. And these are typically represented as task network models, and I'll get into the details of that in a little bit. And there's quite a bit of research around SIGs, and several representation languages have been developed to represent CPGs in a computer interpretable format. These are, languages such as Proforma, FHIR, BPM plus Health, and others. So really addressing this challenge of taking evidence into practice for decision support, it's kind of this, kind of three-step process or two-step process. How do you go from a CPG, which is typically in a textual form, a PDF or a bunch of text, into some structured form, and then finally from that structured form into a computational model that you can then use to provide decision support. So as I mentioned, I will now expand the first acronym that was presented earlier, which is MGCDS. So myself and a lot of colleagues who work in this space, we came up with this concept of a multimorbidity SIG-based clinical decision support, so MGCDS. So that's what I'll be referring to when I say MGCDS. And really the notion here is, how do you build a decision support system that optimizes multimorbid patient management? And there are two criterion that fall in this space. The first is, and most importantly, how do you minimize or eliminate, hopefully, the number of adverse interactions that occur from applying multiple guidelines concurrently? So really what we're looking for is the safest management plan, and then once that has happened, how do you then optimize the management plan according to some patient encounter specific measures? And I'll explain what those are in a little bit. And one of the really important drivers and the focus of today's talk will be that the success of these systems really depends on explaining the rationale behind recommended treatments. So why were certain treatments recommended over others? Why were certain mitigation strategies taken over others to address adverse interactions? And this, as I said, will be what I'll focus on today. So there are several approaches to MGCDS. They take many different methodological and theoretical foundations to address the problem. Here I just list a couple. There are goal-oriented MGCDS. Again, you'll see a lot of the representation task network-based languages show up here. So there are goal-oriented, planning-oriented, and by planning, I mean the AI planning, which I'll get to in a little bit, ontology-based approaches, mixed initiative approaches. So part of the MGCDS work that we've been doing has also been with coming up with a unified framework for evaluation and comparison of these different methods. So I have references later if you're interested in how do you actually compare these different approaches to addressing the multimorbidity problem. And not surprisingly, I'm going to focus on the approach that we've taken to address this problem, which is a planning-based approach, and we'll get into that right now. So our group views the mitigation of adverse interactions problem, addressing multimorbidity problem, as a classical AI planning problem. And what is a classical AI planning problem? Well, it's how do you find an optimal sequence of actions given some initial state that gets you to some predefined goal state, and all those actions are subject to sets of preconditions, and then the actions themselves have some effects, and those effects impact certain relevant metrics that can be used to optimize the plan that you find. So then, given that we see this parallel between decision support and treatment recommendation in a classical AI planning problem, for us, then the question is, how do we represent and encode the multimorbidity planning problem to find an optimal treatment plan? And our solution to this problem is something that is a decision support system that we call MITPlan, mitigation planning. And I'll go through what these components are, but at a very high level, what we have is essentially MITPlan contains a domain, which is all of the actions that can be taken, a problem instance describing a specific patient encounter. All of this is translated to PDDL, which is the planning domain definition language that allows us to then feed that to a planner, which solves the planning problem and outputs a plan corresponding to an optimal treatment plan. So I'm not going to get into too many of the technical details. I'd like to kind of focus more on the intuition behind what we're doing. But here is an architecture or a pipeline figure of what MITPlan looks like. And if you'll see, there are kind of four key components. The first is a representation component. This is where we store information about guidelines about potential adverse interactions. So you need to remember that guidelines are developed to address single diseases and not combinations of diseases. And we have a pre-processing step or layer where we take all of this information together, take all of this information and put it together in a format that we can then compute over, so translate into a computational model. So this is the process of representing all this knowledge in a computational form that we can then pass to a planner to solve. And then we have the last component, which will be the focus today, is on how then do you explain the decisions that were made in coming up with the recommended treatment plan. So to kind of ground some of this work, let me introduce this case study. It's not important to read through it. There's kind of aspects of it that I'd like to highlight. So we're looking at, and I should note that this case study and all the case studies that we consider in our work are developed with our clinical partners. So these are theoretical case studies, but grounded in the real world. So this is a hypothetical, but this is something that our clinical partners see in practice all the time. So we have an elderly male patient who has CAD, coronary artery disease, and also a thromboembolism, DVT. They're being treated with several medications, antiplatelet therapy, oral anticoagulant, and they're newly diagnosed with castration-sensitive prostate cancer. So you see a multimorbidity of three different conditions here. And as part of the new diagnosis, they are treated with a new different set of medications. We have additional kind of constraints on the case, which is this patient recently retired, so they have a preference for lower costs of medication, and also from the physician's perspective, given this patient, they're concerned that the patient sometimes does not adhere to their medication. So then, given kind of a shared decision-making process, what we want to do is come up with an evidence-based treatment plan for this patient that optimizes based on medication cost, adherence, and convenience of medication administration in kind of that order of importance. So then let me kind of show you a little bit of how we encode some of this information in MidPlan itself. So again, we are working from clinical practice guidelines, evidence-based guidelines for individual diseases, which don't encapsulate potential adverse interactions. So we encode what we call mitigation strategies as revision operators. So you will hear me I use the term revision operator, and what I really mean is this is a mitigation strategy to address adverse interactions. And here I'm just showing you kind of two visualizations of two revision operators. One is if a patient is on abiraterone and an oral anticoagulant, then you would want to essentially prescribe the oral anticoagulant and reassess and monitor that patient for 2 days after starting the anticoagulant. Or you see on the bottom here, if a patient is on abiraterone and clopidogrel, then you replace clopidogrel with an ASA and aspirin. So these are the types of mitigation strategies, and I'll kind of do a little bit of a foreshadowing. You see here in the visual representation, there are explanations for why these mitigating actions were taken, and we'll get back to that in a little bit. So within MidPlan, we have a full repository that has different strategies and different strategies for different conditions, and we encode those as revision operators. And within the system, we require either a manual encoding of these, or some work we've been exploring recently about using large language models to do some of this preliminary encoding. And then I had talked about a task network model representation. So this is kind of a bit of an eye chart, but it gives you a sense of what that really looks like. So this is a structure, a kind of a tree-based structure that allows us to encode a lot of the information that's contained within clinical practice guidelines, within revision operators. And it allows us to then automatically process this structure to build the computational models that we then pass to a planner. For those interested, we use graph rewriting methods to embed a lot of this knowledge into this structure. And you can see kind of here, this is just a simplified representation. It's more complex than this, but a simplified representation for the clinical case that I introduced earlier. And you can see we have the ability to encode decision nodes. So for example, tests, action nodes, which are clinical actions to be taken, like administration of drugs or others. We can have parallel paths, alternate paths, branching, different decision points, and things like that. And you'll see here, I kind of highlighted or circled in red, the introduction of nodes to these structures coming from revision operators. So this is kind of the structure that we take, and then we feed it into a planner that allows us to do inference over the patient case and come up with an optimal treatment plan. So what does an optimal or an optimized treatment plan look like? So here's a tabular representation of such a plan, and really it's just a set of actions with supporting data and where those actions came from. So the source of those actions that are provide a recommendation for treatment for the given patient. So you see the first action is administer warfarin. The supporting data behind warfarin administration is provided there. And warfarin administration comes from the guideline that addresses DVT. Okay, so that's kind of what MIT-Plan is in a nutshell and how we come up with optimized treatment recommendations. But what I'd really like to focus on is this notion of explainability. So how do you explain those decisions behind the recommendations with the ultimate goal of making this decision support system more likely to be integrated into workflows and used at the point of care. So there are kind of several or many definitions of explainability in healthcare, and the one that we focus on in this research is the generation of a post hoc explanation of the solutions generated by an AI model. There's also this notion of local versus global explanations, which I'll get to in a little bit, and specifically within the context of automated planning, which is the methodological approach that we use to address this problem. There's this a concept of contrastive questions used to explain the decisions made during a planning process. So these are all things that we consider when we talk about explainability within MIT-Plan. So what does explainability look like in MIT-Plan? Well, we take what we term to be a multi-layered approach. So we're providing explanations at different aspects in the decision support process. The first is we're explaining why specific actions appear in a recommended treatment plan. So this is at the clinical action aspect. The second is why were specific mitigation strategies, again, these are encoded as revision operators, applied to come up with this recommended treatment plan. And then the third aspect, which we call personalization, is how did different preferences, or technically, how did the objective function used in the planner influence the recommended treatment plan selection? And in the previous slide, I had mentioned that there's this notion of local and global explanation. So you could view aspects 1 and 2 as local explanations describing specific actions, and aspect 3 is more of a global explanation that kind of describes the higher level reasoning behind selecting a treatment plan over another. So to ground some of these explanation aspects within MIT-Plan, again, and it's not meant to be an eye chart, you don't need to read through all of these, but the first aspect, so the clinical actions one, really just explains individual actions that are in the treatment plan. So if you look at warfarin, it describes what warfarin is and what it does. And as I mentioned before, and this is foreshadowing again to what we have been doing recently. So the initial generation of explanations within MIT-Plan is done automatically by using an explanation property that is associated with all of the clinical nodes in this task network model representation, which internally we call an action graph. The second aspect of explanations explains those mitigating clinical nodes. So those nodes that are introduced through mitigation strategies. So as The two examples for this case, one was a reassessment and continuous monitoring. The other one was a administration of ASA. So the explanations around mitigation focus on those nodes that are introduced and that are part of the treatment, the recommended treatment plan as a result of addressing adverse interactions. And then finally, the third aspect, which is generated using a variant of graph rewriting. So looking at what are the different treatment plans that would have been generated had you used a different objective function, right? So in our case, we are optimizing the return treatment plan for cost adherence and convenience. Right, and warfarin is prescribed over others because the adherence on warfarin versus, for example, a direct oral anticoagulant is higher because you have to go in to a doctor's office, have your INR measured, and you're more likely to remember to take warfarin over something that you just take at home. So after developing this initial pipeline for generating explanations, we asked ourselves, well, can we do better than what we call as a manually generated process, which is what I was describing up to this point. So you kind of need to look at, well, what are the pros and cons of the approach that we took versus one that uses an LLM. Obviously, as a computer scientist, if you're not working in LLMs right now, are you really a computer scientist? So LLMs are extremely powerful. They're an incredible tool, but they're also not a panacea. So everything has its pros and cons. So if we look at the pros of a manually generated or a manually curated, where in our case, we had a physician generate explanations for each of the clinical nodes in the actionable graphs that we use. You know, those have a high degree of accuracy. They're very relevant, right? But the issue with doing this manually is it's really not scalable. So it takes a practitioners in our case, clinicians' time and effort to really generate these explanations for all of the potential actions that could be in a plan. So shifting to an LLM generated approach, obviously one of the big pros of that is that you can automate this process and it considers potentially all of the data that's available. With the asterisks being, obviously, it's only as good as the data that it's been trained on, right? So when we talk about all data, we're really talking about the data that was used to pre-train this LLM, and I'll get into this in a little bit. And subsequently, the downside of using an LLM approach is that these are trained on huge amounts of data, and they may lack some context. So they may not have enough context for a given patient case. And they may generate inaccuracies, as many people know, hallucinations or even just inaccuracies. And one of the issues really is that there is a lack of an evaluation of explanations in healthcare space that involves HPCs, healthcare practitioners. Right, so typically evaluations of LLM-based approaches are non-standardized, and they don't always consider the clinical relevance of those explanations. And I'll get to what I mean by that in a little bit. So given that, what the problem that we wanted to address is how do we systematically compare manually versus LLM generated explanations that are used in the context of an MG-CDSS. So really, what are physicians' attitudes about manually or LLM generated explanations, right? I mean, just because you can do it using an LLM, that doesn't mean you should. And we wanted to kind of answer that question. And I'm proud to say that, so I'll describe the work we did here, which won a best paper, won the best paper award at the AI in Medicine conference last year. So just very quickly background, I mean, LLM use in medical applications is not new. There are several LLMs for medical applications, MedPalm, Metatron, MedAlpaca, and others. So these are foundational models that have been fine-tuned to the medical domain. Typically, they're used to either answer kind of real life medical queries, so in a Q&A context, or provide some diagnoses from a dialogue between a patient and these models. They're also excellent at extracting patient care information from unstructured or narrative text, such as that found in EHRs. But I will say that kind of their use in complex patient cases is rather limited. And by complex patient cases, what I mean are those that include multimorbidity, polypharmacy, or longitudinal care. And as we know, one of the downsides of LLM use in general is that they can hallucinate, right? They are trained to always provide an answer. And, hallucination in that case is really, a gap filling phenomenon, right? So if an LLM is tasked to reproduce some knowledge that isn't present in the training data, it's going to make it up. And that's an issue especially prevalent and important in medical applications. Okay, so what we wanted to do then is to have physicians evaluate LLM generated explanations. So there really is a need to assess them both, holistically, that they're safe and appropriate. And really, as I mentioned, there is a lack of standardized evaluation dimensions. So there isn't an evaluation instrument that can be used here. And even across evaluations of different models in different healthcare contexts, there are discrepancies in how the evaluation results should be operationalized. So I'm going to talk about MedPalm. I'm not picking on them because I think it's great work, but this kind of some of the results that they report highlight this issue that not all of the findings in these evaluations of LLM generated explanations are generalizable. So first, the MedPalm work found that LLMs perform comparable to or even outperform physicians across different measures, such as utility or alignment with domain knowledge or reading comprehensions and others. But then in the exact same work, you also see that them reporting that physicians outperform LLMs in reducing risk of harm. And they typically have less inaccurate or irrelevant information, right? So then the question is, how do you generalize and operationalize these findings? So for us, what we did, the approach to generating explanations for this study that I'm describing, we had two versions of explanations. The first are manually generated. So this is kind of the process that I very briefly described earlier, where each explanation is created automatically, but from manually curated text by a physician that's embedded into the representation of guidelines and everything that MidPlan uses. And we do have work that we published in JBI last year that showed that these manually generated or manually curated explanations had high fidelity and interpretability when evaluated by physicians. So then on the other side, what we wanted to see is, well, let's generate these explanations using an LLM. So we used a Metatron 70 billion parameter model. I will say beforehand that there are newer models than what we used last year to do this work, but that wasn't available when we did this. So we used the older Metatron model, and we used the zero-shot learning with a RAG prompting approach, where we provided the full patient context by using the description similar to what I showed you earlier when describing the case study. And then I will note that the LLM output, so the explanations generated by the LLM, were post-processed for clarity and to avoid repetition. We didn't want to make it obvious to the participants in the study which one was the LLM generated, which could, potentially use to a bias towards their evaluation. And again, both approaches, manually and LLM generated, created explanations for each of the three aspects that I had mentioned earlier. So the clinical, the revision, and the personalization. So the evaluation really set out to determine a physician's attitude towards explanations generated either manually or automatically with an LLM. So we wanted to evaluate their preferences and maybe as a secondary finding some limited measures of the quality of those explanations. So what we did was we had two realistic complex use cases. The first is the one that I already described earlier, and the second was a similar case of a middle-aged man diagnosed with CAD, treated for DVT that develops gastrointestinal bleeding. This was a small study, so we had 5 physicians who specialized in hematology and oncology. So how do we design the evaluation? So we provided the case description and the recommended treatment plan to each of the study participants. For each unique clinical action, which there were 10 across both of the cases, MIT plan provided 2 explanations. And the physicians were presented with both explanations, and they were marked as A and B. So they weren't identified which was manual and which was LLM. And then we asked 6 questions about specific evaluation dimensions. And those dimensions I list here. I will just, before I describe what they are, I will say these dimensions and the questions asked were inspired by the system causability scale and also by the evaluations done by the MedPalm 2 model team. So the dimensions are evidence, understanding, detail, relevance or irrelevance, accuracy, inaccuracy, and self-containment. And you see what the evaluation question is for each of those dimensions. And the response scale was either explanation A, explanation B, both, or none. So we considered pairwise comparisons with ties, and that's why we used an atypical scale. And you'll see how why that was important. All right, so what did we find from this evaluation? So if we look across all aspects, right? So clinical, revision, and personalization, we found the following findings. One thing I will say before describing these is that the analysis broke up responses into discriminating, so either LLM or manual, and non-discriminating, so either both or a preference for none. And to determine if explanations from a particular source were preferred by the study respondents, we used a paired sign test that tested essentially whether one condition is preferable to another in the context of paired responses. So what we found was that across the inaccurate and irrelevant dimension, The results were highly non-discriminating, so there was really no differences in the evaluation of manual and LLM generated. Across in the evidence dimension, we found a statistically significant difference where the LLM was preferred over a manually generated one. And for understanding detail and self-containment, we found no statistically significant difference. So then we decided to break down the results using the different aspects, so different combinations of the aspects. And we used a one-tailed test for the combinations of aspects. So for the clinical aspect, meaning explanations for individual actions not coming from revisions, we found that statistically significant results that the LLM explanations better reflected evidence were better self-contained than manual ones. And when we looked at clinical and revision aspects together, the LLM again was preferred in that it better reflected evidence and they were considered to be more accurate. So essentially meaning better explained revisions were made. There is a caveat, which I'll get to in the next slide. We found no significant differences for clinical and customization aspects and for all three of them combined. And this is likely due to the relatively small number of responses within these combinations per action. So this is a limitation of the study that we hope to address in future work by increasing the number of participants. So just to kind of discuss our findings, we think that this was the first study that evaluated the use of an LLM for explanations for complex patient cases, specifically around multimorbidity. Generally, LLM explanations were found to be as good or preferred to ones that were what we term manually curated by a physician. As the results show, these LLM generated explanations typically are considered accurate, relevant, and grounded in evidence. But there is a but. So here I'll put up an example of an LLM generated explanation around warfarin. I again don't need to read the whole thing, but the punchline is in the first sentence, which is warfarin is not a direct oral anticoagulant. It's actually a class of anticoagulants known as vitamin K antagonists. I would say most, but not all of the physicians caught this inaccuracy. So this points to, a potential clinical practice implication of over-reliance on AI in decision making. And we actually had one more kind of more subtle falsehood that the LLM hallucinated, and this was that it included in the explanation of abiaxaban, which is a medication prescribed to mitigate gastrointestinal bleeding. The LLM generated explanation referred to an existing and real clinical trial, but the results that it presented from that trial were actually incorrect. So the numbers that were reported as far as lower rates of major bleeding when compared to warfarin were inaccurate, and that is not something that any of the participants were able to identify, because you wouldn't know that unless you probably wrote the results paper for that trial. I will note that GPT-4o was able to capture and correct both of these problems. So we see that with the evolution of LLMs, some of these issues do get addressed, but others arise. So a few limitations of this study. As I mentioned earlier, this was done on a relatively small scale and also with a fairly homogeneous group of specialists. They were all fairly senior, so there wasn't a range of experience levels. And as I mentioned, LLMs are ever evolving. Anytime you do any of this work, as soon as you publish it, there are newer versions of LLMs that have different properties, both positive and negative. So this is an evolving space. So a few key takeaways before I finish. So clinical decision support for multimorbidity is hard. It's a complex problem. You have to deal with polypharmacy, with adverse interactions. Patient contexts are very important. And all these things need to be considered at once. AI broadly can really help address this problem. My background is in data integration, so it really does enable a sophisticated data integration. It allows you to do some complex reasoning, not within the LLM itself, which we could have a whole nother discussion, but more broadly in the context of our decision support system, we do some fairly complex reasoning, and it allows us to explain the decision-making processes, which hopefully improve and enable better integration and uptake of the decision support tool in practice. And LLMs really do hold a lot of promise. So it's an incredible technology. It's an incredible tool, but it also needs to be applied thoughtfully. So again, it's not a solution to everything, and I'm happy to discuss that further if needed. So finally, what are we doing right now? We're focused on kind of two key aspects, and I'll flip them in the order that they're described here. So the first is we are currently updating our survey instrument and recruiting for a much larger US and Canada study where we are targeting more specialties, a range of experience levels, a range of HCPs, so not just physicians, but also nurses, and a broader set of use cases that we have already developed to evaluate LLM-generated explanations in decision support. And what we're really interested in, we've submitted some work that's currently under review, is building an automated tool to measure the quality of explanations in the context of a patient case. So what we're really trying to figure out how to do is how do you assess the clinical usefulness of an explanation, right? So and how do you build an instrument to do that? Just because an explanation there are a lot of dimensions for what a good explanation is. And one of those that is not being considered currently is the clinical usefulness. So it may be a good, from a methodological perspective, explanation, but it may not be useful clinically. And how do you measure that clinical usefulness aspect is one thing that we're doing. So I just wanted to thank the research team. This is a truly interdisciplinary and global research that we're doing, and I'm just presenting it on behalf of many people who have helped us get this far. And if anyone is interested, I'd like to point you to the Met Research Labs website, and also that one is focused on the decision support work, and then the cognitive AI research lab that I help run at the U of M, where we have a lot more work focused on LLMs and large language models. So with that, thank you, and I'm happy to take any questions.
Thank you so much for this really great presentation. Just to remind all our attendees that you can post your questions using the Q&A feature on your Zoom interface. And we actually have received already questions as you were speaking, so I'll try and go through some of those. realizing that there may be also questions about points that you later addressed. So the first question is from Dr. Lohman, who says that you had been addressing a significant clinical challenge with a promising solution. What do you do when patients have clinical diagnosis with no clinical guidelines? For example, long COVID, which affects 20% of patients in the US with no FDA diagnostics or treatments.
Yeah, that's a great question. And I will say that given the assumptions that we make within this decision support system, that's not something that we currently address. Our underlying assumption in creating a planning problem is that there always is a solution. So there always is information available on what actions can be taken. So we don't currently have the ability to figure those out. We base them in evidence-based guidelines. So that's kind of our, one of the underlying assumptions that we make.
Great. Another question is about the trade-offs with using LLMs or GPT-style framework to complete your encoding.
Uh, there are many. So I think, from one perspective, as I said, LLMs are an incredible tool. It allows us to scale. It allows us to incorporate a lot more knowledge than we could realistically do from using a manual perspective. But the trade-offs are cost, our privacy as well, and deployment. We use open weight models like Llama, and Metatron is a fine-tuned version of Llama that make deployment a little bit easier, but not easy. There are computational costs. There are also I'll just touch on this because it's a whole longer discussion, but one needs to remember what an LLM is. It's really just a probabilistic model that's predicting the next most likely token and not actually doing any reasoning. And there's a lot of nuance in addressing the multimorbidity problem, in the sense that patient context is very important, and the difficult aspects of the decision-making process are in those cases that you may not frequently see. And a large language model is not always ideal at providing information for those kind of needle in a haystack situations versus those that it's trained on, which are large amounts of data that occur more frequently. So those are some of the trade-offs, I would say.
How do you clean the data at the onset? There are on average 7 errors per page in medical records, according to FHIR working group. So when you have garbage in, you have garbage out.
Yeah, so I will admit that we manually process the data coming in. So our focus from a decision support perspective makes the assumption that we have good data coming in. So we have accurate representation of the knowledge over which we need to reason. But I fully acknowledge that that is maybe that is a significant assumption. We have published some work on how to convert a lot of these different CPGs, again, from textual to a structured form that we use. And we also rely on other people's research as far as translating textual knowledge encapsulated in these guidelines into meaningful and correct knowledge that we use to reason over.
Great. I know we have lots of questions. Let me see here. What is your vision for evaluating LLMs by academic researchers when an academic study can be out of date by the time that study is completed?
Yeah, I mean, it's a great question. And I think, as I mentioned here, in one of the limitations and even takeaways from this work is that the space of LLMs is ever evolving and it's impossible to keep track. So I think or I should say not keep track, but stay current. I think for us, and as I mentioned in our kind of current and future work, we're really focusing less on which LLM we're using because we've kind of hit the point where most LLMs, at least in their current structure, have kind of gotten close to the ceiling from a performance perspective. So I think we've gotten to the point where it's less important which LLM we use, and it's more important that we consider those aspects of evaluating LLMs in a healthcare context that's important. And that's where our work around how would you automate and build an evaluation instrument for clinical usefulness? That, in a sense, I don't want to say it's LLM independent because we do use LLMs to generate those explanations, but the kind of the broader idea of how can you evaluate these explanations in a healthcare context that gives us a little bit of leeway in that I don't think it's tied to an individual LLM model, but more kind of a class of, fine-tuned models for a medical applications that perform well enough or to a certain standard. And I think we've kind of hit that with LLMs. So we're focusing more on the implementation and clinical perspective side of things now.
There's a question about, since nurse practitioners prescribe meds, do you plan on having NPs participate in future evaluations?
Great question. And I'm glad someone asked because I am in the School of Nursing. So I do think about nurses and the implications of these explanations on their work as well. And the answer is yes. Actually, one of my PhD students is working on recruiting a large set of nurses, different types of nurses, to help in evaluating because explanations are different and will be evaluated differently based on role, whether it's a physician, a prescribing nurse, or somebody else. So yes, we very much are planning to diversify the HCP population for our work, and nurses will most certainly be part of that that next cohort of study participants.
That's great. Has the paper on providers' acceptability on the manual versus LLM-generated explanations been published?
Yep, that is, and I do have references at the end of these slides. I don't know if these can be shared, but it was published in the AI in Medicine conference proceedings, which you'll see the second to last reference on this slide is that paper.
Great. And there have been questions about the presentation and the recording. The recording of this presentation will be available on our YouTube channel in a couple of days, so people can also watch it there. And also, somebody was asking about the PowerPoint for your presentation. Martin, if you feel comfortable, we can share it to attendees, or maybe they can contact you directly to share any slides that you feel like sharing.
Yeah, I'd be happy to send you a PDF of the slides, or as I mentioned, please feel free to send me an email with questions or a request for the slides.
Great. I know we have many more questions, and unfortunately, we're running out of time. So I would suggest that you email Martin directly to continue that discussion. This has been a great presentation that clearly generated a lot of interest. Just a reminder, our next webinar is on April 10th with Dr. Philip Payne from Washington University School of Medicine talking about AI and the learning health system. Again, Martin, thank you so much for joining us today, and thank you all for attending.
Thank you, George, and thank you, everyone.